All right, so I hope that was a helpful tutorial for everybody on screen sharing on Zoom. I'm going to talk a little bit about contraception across the gender spectrum, as Julie had alluded to. For disclosures, I don't have any financial disclosures, but also want to make some acknowledgements and shout out. So some of the slides in this talk are adapted from Dr. Corinne Heinen, who's at UW Belltown Clinic, who helps organize a lot of education in the UW system around transgender and non-binary care. And shout out to the Trans Health Elective, which is just an abundance of resources. You get to work with some amazing colleagues, including Lauren Campbell is making a guest appearance today. And another just acknowledgement that I am not an expert. I'm continuing to learn. And I really love learning from you all. And I've seen that folks are adding things in the chat. So please continue to do that. And I am really appreciative of this time to get to learn all together. I also want to share that To Survive on these shores is just a really amazing project, and spending some time looking through those interviews and photos is time well spent. Also want to echo again that data is limited in this area, and there's a huge need for more studies and further research. A lot of what I'll be presenting here is from a publication called Contraception Across the Transmasculine Spectrum that was published in the American Journal of Obstetrics and Gynecology a couple of years ago now. And the creation was led by reproductive care clinicians of the transgender experience. Outline and learning goals. We will review how to take or how to ask a gender inclusive sexual history, identify situations in which contraception would be recommended, utilize appropriate contraceptive methods that align with gender affirming care goals, and then identify resources for family building and fertility preservation. Okay, so our case continued. Ash is back for a clinic visit, for an annual wellness visit. We start off with some stellar agenda setting, ask what he would like to discuss. He mentions, I started dating someone recently. Since I'm on testosterone and I don't have any bleeding, I can't get pregnant, right? And as Julie had talked about earlier, important to remind Ash and all of us that testosterone is not a reliable form of contraception. There is some literature out there that has sort of looked at this question, but there's no prospective studies to date that evaluate the effect of long-term hormone therapy on fertility. Most transgender men who have had regular menses before starting testosterone are reported to resume menses if the testosterone is discontinued. And there was actually a study, I think it was a fairly small study, but 20% of transmasculine respondents in that study who experienced pregnancy were amenorrheic and on testosterone at the time of conception. We also know from other literature with like PCOS and congenital adrenal hyperplasia that androgens impair but do not fully prevent ovulation. And then there was actually a UW study recently, a couple of years ago, that looked at initiation of testosterone and showed that it does cause rapid suppression of the HPO axis. But even for folks who have been suppressed for months, there can be occasional ovulatory events. So good things to keep in mind. And then another thing that can come up, and we talked a little bit about with estrogen and access to therapies, is that there can be a lot of barriers to accessing consistent hormonal care that can lead to missed doses, incomplete dosing, or switching between preparations that could influence breakthrough ovulation from incomplete suppression. So the takeaway point there is that testosterone is not a reliable form of contraception. I'll just briefly touch on feminizing hormone therapy, also not a reliable form of contraception. As Julie had pointed out in some of the slides earlier with the effects of feminizing hormone therapy, one of the effects is decrease in sperm production, but onset a little bit unclear. And it's not necessarily, sorry about that, not necessarily a permanent change. So we'll go to the next slide. So when do you recommend contraception for folks? And some of this goes back to asking a gender inclusive sexual history. And one way to help kind of remember hitting all of the pieces is thinking about the 5 Ps for people that like, I guess it's not necessarily an acronym, mnemonics, but the 5 Ps, so partners, practices, past history of STIs, protection from STIs, and pregnancy plans. And just remembering again to make this routine, with all of your patients, confidential, free of assumptions related to age, anatomy, gender, and ability, explaining to patients why it's important, asking open-ended questions, mirroring patients' language if possible, as both Julie and Caitlin mentioned in their talks. That's really the best way to go. And then another thing that Julie mentioned, I'll echo as well, is that really like your tone and rapport matter as much as the questions and terminology themselves. And just remembering that we're here to genuinely like help folks in being able to feel more like themselves. And I like that the business of bringing joy. Okay, so asking a gender inclusive sexual history, I won't spend a ton of time on this since I think it's been covered at other points in our training, but some of the questions that are important to ask are, what is or are the gender or genders and bodies of the people that you have sex with, and asking about if the patient or client or their sexual partners have had any surgeries that affect the genitals or sexual or reproductive function. This is where that anatomic inventory can be really important. And there's actually a really helpful tab in Epic that sometimes folks use to sort of document the anatomic inventory. I haven't seen it used a ton, but it's one place that can be helpful. Let's see, and then asking about the pregnancy plans is really, really important. If there's any interest in having genetically related children or pregnancy now or in the future. Again, this isn't a comprehensive list of questions. Remembering to screen for interpersonal violence is important, and some of the questions that Julie had mentioned earlier too, about like finding yourself in positions where you're needing to exchange sex for money or substances are all important questions to include. This is just a reference that you can use for maybe when you aren't able to mirror patient language or you're just getting started, ways to use less gendered language. So instead of using terms like pregnant women, people who menstruate, people who are pregnant, and for breast, using the term chest can sometimes be more comfortable for patients. There are obviously some patients that would prefer to use the term breast, so mirroring that language. But this is just a reference to use for if you're looking for language that's less gendered. So with our case continued, so Ash shares that new partner June is trans feminine, plans to start feminizing hormone therapy soon. She's not had any gender affirming surgeries. They have not yet had sex, but talked about the possibility. Neither have other sexual partners. Ash has not had any gender affirming surgeries and does not desire pregnancy at this time. He might want genetically related children in the future. So how do you counsel Ash regarding pregnancy risk and contraception? I'll just let you sit with that for a second. And then talk about some factors that can influence recommendations for contraception. So again, what organs are present is a really important question. Does the individual desire pregnancy now? And do they desire future use of their uterus or ovaries? Does the individual have receptive frontal sex with people who produce sperm? And does the individual want a hysterectomy or oophorectomy? Are all things to think about. And then from that paper I had mentioned, there's this flow chart, which I think is pretty handy on going through some of those questions. And if we, followed for ASH right now, so ovaries and uterus are present, does not desire pregnancy right now, may be considering having receptive frontal sex with an individual who produces sperm, so would recommend contraception. The one thing that's starred here, and I'm not sure if other folks have more information about this, but in terms of when pregnancy is desired, I don't think that there's a lot of data on the safe washout period for testosterone. Testosterone is teratogenic. And so I think the general advice is waiting at least 2 to 4 weeks. It's a little bit dependent on administration. I'm sorry, the route of administration. But if folks have other information about this, please feel free to add to the chat. And right. So contraceptive options. So all options are can be offered to folks who are taking testosterone. It's not a known contraindication to any form. Again, considering future desires for fertility. A lot of this is similar counseling as for cisgender women. The additional unique concerns and needs to think about, as Julie mentioned before, some folks do have sources of gender dysphoria. Some do not have sources of gender dysphoria, and it's not the same for all people. And so really asking, the person in front of you, what are the things that they are worried about with any of the contraceptive options. For some folks, it's anatomic concerns, that there might be changes to the chest or breasts, or changes to genitals. For some folks, it's physiologic, that menstruation or pelvic cramping can cause and induce a lot of dysphoria. And then for others, just repeatedly taking a medication that's generally associated with cisgender women, like combined hormonal oral contraceptives, can induce dysphoria. And so again, different for each person, important to think about those things and ask. Some might be worried about the perceived feminizing effects of estrogen and or progesterone. Though from what I have read and heard, it oftentimes there's not enough or sort of the amount of estrogen in pills are not likely to contribute significantly to preventing masculinization. So usually not too much of a concern. And then the other consideration is that is more likely to seek menstrual suppression than cisgender women. So being aware of which contraceptive options are more likely to result in that. And then contraception can also be used for abnormal uterine bleeding. There's a couple of extra slides that I put in, but the takeaway from that is that it's important to think about all of the possible causes of abnormal uterine bleeding in folks who are transmasculine. Okay, this is a table that I'll mostly I'll talk briefly about, but it can be a good reference for when you're thinking about contraceptive methods and with transmasculine specific considerations. So for example, I just highlighted the IUD since that's a common one that's commonly used. the things to think about is that it's an invasive pelvic procedure. So either may not be the best option for folks who have a lot of pelvic dysphoria, or would just really need to take a lot of sort of preparatory like steps and precautions with folks if they did decide that that's what they wanted to do. I think another thing that's interesting or important to think about is whether a clinician is needed to discontinue. I think just the some of the concerns about the possible effects of contraception on sort of body changes can make the barrier to starting a little higher. And so some methods where the individual themselves is more easily able to just to stop using it can sometimes be a better option. So it's just a good table to refer back to and thinking about across the top some of those specific sort of considerations or sources of possible concern or dysphoria. And this is just a brief a table showing some of the rates of amenorrhea with some of the different long-acting reversible contraceptive methods. And so for folks who are really interested in menstrual or bleeding suppression, uterine bleeding suppression, this can be a good reference. Going back to thinking about the considerations for invasive procedures, so things like an IUD placement also would apply to cervical cancer screening, speculum exams, counseling well in advance what to expect, encouraging presence of a support person if that would be helpful for that particular individual. For transmasculine folks who have been on testosterone for more than 6 months, they'll have some loss of elasticity and considering a narrow or an extra narrow Peterson speculum. And then if there's lead time, if there's sort of a planned exam or procedure using some intravaginal estrogen for 4 weeks prior to help with elasticity and lubrication can be helpful. And then using anxiolytics around exams can also be helpful and important to offer. I think I'm interested to see too where we go with sort of like self-collect HPV swabs for cervical cancer screening. And maybe someone who might know more about that can throw more in the chat if they know within our system if folks are doing that more. This is a resource for patients that I just put the link in. It's uses like very like lay language about birth control across the gender spectrum. And then I also wanted to mention just trans-friendly abortion providers in the Seattle area. This is from the Ingersoll Gender Center. So the Cedar Rivers Clinic, Planned Parenthood, our UW Medicine Family Planning Clinic. And then just a little bit of information and a link to a paper there about abortion experiences and preferences of transgender, non-binary, and gender expansive folks in the US. So we'll go back to our case continued. So Ash returns for an annual wellness visit a few years later. And he tells you that he and his partner June are hoping to start having genetically related kids, and they are wondering about next steps. I mostly am providing sort of links to resources and information here. There are a variety of options for family building and fertility preservation for transgender, non-binary individuals. And options should be discussed regardless of where they are in their gender journey. There are several organizations that do recommend discussing before initiation of hormone therapy, but talking at any point in the gender sort of journey and process is important because there is such a variety of options. There's relatively limited data, though, specific to fertility preservation for transgender non-binary individuals. It's primarily extrapolated from oncologic diagnoses. Some local resources that that you can help connect folks to are the Ingersoll Genter Center, Pacific Northwest Fertility, and Seattle Reproductive Medicine. And if any of the folks who are a little more linked into reproductive medicine have other local resources, please feel free to add those in the chat too. And then there's a great webinar that the National LGBTQIA Health Education Center has available. It's free, you just have to create an account, but that covers a pretty comprehensive reproductive care and OB for transgender and gender diverse folks. This is just a table kind of showing a lot of the different options. It's from the Mayo, sort of Mayo Proceedings paper. Some of the options are sort of still experimental, either in the US or worldwide, but I won't go into a ton of detail with that. And then the big takeaway points. So important to use a gender inclusive framework for asking sexual history for all patients. Masculinizing and feminizing hormone therapies alone are not reliable forms of contraception. All forms of contraception can be offered, and also consider unique concerns and needs for contraception in transgender, non-binary, gender expansive individuals, in particular thinking about specific sources of gender dysphoria. And then family building and fertility treatment and preservation options should be discussed with transgender non-binary folks at any point in their gender journey. Utilize available local and national resources. So just a link to some additional resources, and then we'll maybe pause here, see if there are questions, and talk with Cam about how he wants to approach the next steps.
Yeah, guys, I think we should not worry. If I were in our listeners' shoes, I probably would not want to go into another rushed presentation. So I think that rather than trying to fill the last 15 minutes with a talk, maybe we should open up to questions, and I will bully all of you into coming back on the 3rd of March for a talk on gender affirming surgery. And also I wanted to say, we've been saying, sorry for my pager going off. We've been saying this in the chat, but thank you so much to Dr. Lauren Campbell for chiming in. It's been really, really awesome to have your perspective here. Thanks for helping us to answer questions. Sorry, Anisha. But yeah, we'll take questions now if it would be helpful.
Is there anything, I noticed that there's a lot that I didn't see in the chat. Is there anything that folks want to highlight from the chat that I may have missed?
Lindsay, just a lot of great references and additional information to fill out some of the details of what you were covering.
I have a question for the Caitlin, who I believe is doing the adolescent medicine, which is awesome. I am curious, at Fenway, we did often see folks who were transitioning from being in medicine with family medicine or pediatric providers into adult medicine, who may still be on blockers. And then there's always the question of when to come off, when they're also already on estrogen therapy, and they're having good results. And so often that transition off of a hormone or puberty blocker is really a tricky time for folks, especially if we then need to put them on Spiro, which has its own set of side effects. So curious if you've seen that handled in different ways and how folks have reacted.
I was worried about this question because I don't know the answer. I wish I knew more. It's not something I've really seen yet, at least in my 2 weeks in gender clinic so far, but I'll definitely reach out. The adolescent medicine providers have been super awesome at like answering a lot of my questions that have come up, especially in putting together this talk. So I will chat with some of the providers I'm working with about that question and hopefully learn more.
I can chime in a little bit, Caitlin, just from what I saw with Dr. Hatfield. So a lot of us reference Dr. Hatfield a lot. And if for people that don't know him, just he's over at Polyclinic, he's family medicine, and he's the one who he has like a scribe and sees like 40 patients in a day. And so you're able to see a lot of this, a lot of gender care. He actually keeps in the blockers for I think a lot longer than maybe is recommended. And he feels pretty comfortable doing that. And he's had patients that go straight from the blocker to an orchiectomy if they're really, if they feel really sure about that decision. But I think he was even keeping them in for like 5+ years, 6 years, and was kind of saying that in his experience, and I don't know if this is not data driven, right? But that in his experience, he wasn't seeing things like testosterone levels increase after like much longer than the manufacturer was advertising, and was even using that to avoid putting people on the $40,000 replacement blocker when they originally had the $4,000 one.
And Julie, are most of Kevin's patients on like the Hystrelin implants, or are they also doing Lupron?
Hystrelin, I think.
Okay.
Maybe some Lupron, but mostly from what I saw, it was the Hystrelin, yeah.
I have a question about patients with like higher VTE risk in hormone therapy. I had a patient who was inpatient. She was a trans woman who had a history of multiple myeloma, and her initial provider for gender affirming care empirically started her on anticoagulation when she was diagnosed with multiple myeloma. Is that like standard of practice to anticoagulate someone who has like a higher VTE risk?
I don't think it's standard of care. I mean, it might have been the right decision for that individual patient, but it's not something that I've encountered. What I have mostly encountered is just folks trying to minimize the contributory VTE risk from estrogens by making sure that they're on a topical estrogen rather than on some other formulation, and then anticoagulating once, a clot arose. But that's just what I've seen. I don't know.
Yeah, it's not typical to proactively anticoagulate in folks at higher risk. The Dutch cohorts, which shows a group of transgender women on hormone therapy, they saw a VTE risk of 2.6% in the first year that folks were on estrogen therapy, which went down to 0.4% after that. So it really, we think about once folks are on hormone therapy for a longer time, their risk is so much lower and it's so much higher should they need to restart, that we'll often, recommend continuing through most things. And I've even consulted hematology when folks have had issues with clots and they say just continue. There's not a need to make any changes necessarily if folks are stable on their hormones. So it might have been a unique situation with that person, but it's not something that I have done or seen done, even in consult with hematology and hematologists who have knowledge and interest in working with gender diverse folks.
Great, thank you.
This question might.
Sorry.
Oh, sorry.
I was just going to say one thing that I say a lot is that we treat VTE with anticoagulation and not castration. So I like try to say that because I have encountered in the past clinical situations, it's like, well, somebody's got a clot, we should stop their HRT. And I think that's probably not a good approach.
Oh, sorry.
I was just going to say, you also might get pushback from surgeons in your jobs as internists who say you should stop people's estrogen because they are getting surgery. I highly do not recommend that because, again, the highest risk is restarting and it's clearly not affirming for the patient. So we recommend they continue their hormone therapy, and please push back against surgeons who are still using that practice.
And we have emerging data. You can point them towards studies now that have come out like in the last couple of months. So say you don't have to stop.
I guess I sort of start to answer the question that I have. I think, unfortunately, the thing that I've heard so often from everybody in the last couple hours is this is not a data, or this is a data-free zone. This is not data-driven, like all these different things. There's a lot of personal practice. And I understand that because it's an emerging like field for standardizing of practice. And a lot of it shouldn't necessarily be standardized because should be customized for the patient. But is there like a central repository for listing all the ongoing studies? I suspect that a lot of these things are going to be like retrospective cohorts, not a whole lot of like prospective cohorts. I'm not really sure about like, is there like a group that's really organizing to answer specific questions? Because right now, I don't know, it just seems like a bit of a disservice to all of our patients if there are a lot of people who are very well intentioned, but we don't have, I don't know, like every time we come up with the question of anything and we can't actually answer it beyond anecdotal data, it seems like we're just not really serving our patients in the best degree that we should. So I guess my question is there like an area that lists out all the studies and the current questions that are being asked? Seems like a no.
I am not aware of a central repository. Unfortunately, I think a lot of the data that are emerging, yeah, we do need a wiki, are coming out of some of the like what we might have traditionally thought of as like the LGBTQ health powerhouses. The much referenced Fenway Health being one of them. I think that the studies are being archived a little bit on sites like the UCSF Transgender Health Guideline website, but I haven't encountered a good central database. So if somebody wants to do that project, that would be really helpful.
I would say that WPATH, which is the worldwide group essentially promoting gender diverse health, has meetings annually and update meetings. Fenway Health has the LGBTQ Health Education Center, which you all have access to. It's free. It has online lectures that you can access for free and are amazing. So that's another resource that folks can access, and both of those list their references. I think the next, if anyone wants to participate or has any time in residency to participate in a meeting, the next meetings for both of these groups are in September and October of this year. And so those are times that folks are going over updates. UCSF has good, I mean, they reference their data as well, but I think if anyone, and on the Fenway website, you can actually go through their reference guide, which lists the studies they're looking at. I can try to post it in this chat here too.
Yeah, because I kind of think about how, I don't know, maybe in like 15, 20 years, how wonderful it's going to be when we have like our set of guidelines and we have like our grading system for what studies have been done and what things are, recommended by different groups and stuff. So I don't know, just things to look forward to.
I think one of the things that we're also looking forward to is having people like Dr. Campbell that have joined faculty, and for a lot of us to have some guidance too, because most of us that are residents that are seeing a lot of patients, like when I have a patient that's trans and I'm trying to troubleshoot some things, I literally have no guidance. I have nobody that can help me, and I've taken care of more trans and non-binary patients than I think most of my attendings have at this point. So it's really awesome that we have these incoming resources that can help us be more organized and data-driven about it. So, big plug for continuing to make that a priority in recruiting faculty.
I'd also probably say even in addition to that, Julie, like less traumatizing for the patients too, to like have like, we already know that having short 3-year relationships with residents and patients the transition can be pretty traumatizing when they go to a new resident, but especially when somebody who's very well informed on the care and there aren't a lot of other people, to have attendings like Dr. Campbell coming in to maybe bring some sort of continuity with those things. Feels like a systemic thing that we can maybe try to help push for too.
Yeah, and those of us in the Madison clinic, it's a double whammy because oftentimes they've just been diagnosed with HIV and are also interested in in transition care. So there's a fair amount of hardship associated with our turnover.
As an aside, HIV is my other area of interest, so it's definitely something where we have that overlap, at least through the VA, and I'm happy to answer questions or work with folks if there are things coming up around that.
We were talking a little bit about the listserv, and Lindsay is right. The best way to join the trans care listserv, which I strongly recommend because it's a lot of great conversations about things like where to access resources for hair removal that might be covered by insurance, that sort of thing. The way to access that listserv is to email the people who are in the chat, most specifically Dr. Corinne Heinen. And it looks like a program coordinator named Sean as well.
Sean is super, super knowledgeable. If you need help with resources, how-tos, letters, anything, they're fantastic. But I haven't actually met them in person yet.
Awesome, guys. I think we're getting to 11:30, which probably means it's about time for us to part. I'll turn things back over to Nina, but again, just to put in a plug to come back on the 3rd if you want to talk about things like how to write a letter of support for gender affirming surgery and that sort of thing. I know that practical stuff can be really tricky.
Thanks so much to our speakers for a really wonderful morning and all that hard work that you put into your discussion. I will save the chat and I'll send it out in an email right after this so that we have the info to refer back to and the links. And then just to plug again, it goes out in the weekly emails, but there is the digital OneDrive curriculum folder. So when we do have the slides available to us, then we post it up to the website. And then these are also recorded to the YouTube channel for the program. Okay, with that, we'll break. Thanks so much, everyone.